Hello, and welcome to the Frailty in Primary Geriatrics Care Educational Module. My name is Huisingh-Scheetz. I am a geriatrician and clinician investigator at the University of Chicago, and I am very happy to be with you here today. This module is part of an educational series about frailty, which can be found on the Frailty Science website. I hope this session will be very practical for you and will include some helpful information. I hope to share with you some ways that frailty assessment can impact clinical decision-making in primary geriatrics care. I hope to share some clinical infrastructure that might facilitate frailty assessment at your institution. And I also hope to outline some remaining challenges to frailty implementation in daily practice. I'll start by reviewing the state of frailty science from my perspective as a geriatrician. Then I'll share how we have implemented the frailty assessments into our routine geriatrics ambulatory care at the University of Chicago. I'll end with a few remaining challenges that I think need to be addressed in future geriatrics research to facilitate translating frailty science into primary geriatrics care. So first, a little background. Older adults represent a very broad and physiologically diverse group of people. And as it turns out, as the health variability among adults 65 and older is actually getting wider over time as people and sicker people are living longer. We can't always distinguish this health variability using the eyeball test. We know from geroscience research that aging is associated with a loss of physiologic complexity, shifts in energetic utilization, reduced homeostatic capability, and these changes start at a molecular or genetic level and then lead to dysregulation across physiologic systems. These changes all begin occurring before they are clinically evident. Frailty then is the clinical manifestations of these underlying aging physiologic deterioration, which we can use to help differentiate vulnerability to poor outcomes. Since the introduction of what I like to call the modern definition of frailty, there has been a proliferation of tools. This can be a little confusing for some people. While I do not have time to discuss the pros and cons of these tools today, there are some domains that are consistently represented across these tools: limited reserve, reduced endurance, and diminished strength. Frailty was officially defined by an expert panel as a medical syndrome, or what I like to think of as a state of health with multiple causes and contributors. In a typical syndromic fashion, frailty is characterized by a group of clinical signs and symptoms that capture this diminished strength, endurance, and reduced physiologic function. The presence of these clinical signs then identifies someone who is at risk for dependency or death. There are many examples of frailty predicting poor outcomes in the literature. This includes poor outcomes on everyone's radar: rehospitalization, high healthcare utilization, delayed recovery from acute illness. Frailty has also been associated with various important biomarkers, including inflammatory markers, cortisol levels, and loss of the diurnal cortisol variation, and changes in the cardiovascular autonomic nervous system, including things like loss of heart rate variability. Evaluated over longer intervals of time, here 5 years, frailty is a chronic and progressive syndrome. However, in the short term, there are actually a lot of frailty state transitions. We note here frailty transitions among some patients of ours for whom we have local 1-year follow-up data. And you'll notice that the general trend is for people to have worse frailty status even at just 1 year. However, there is some movement to lesser frailty states. This finding suggests that in some, frailty may be modifiable. Besides this growing literature base recommending frailty be integrated into primary geriatrics care, there are also other efforts supporting this as well. This includes the 4M's Age-Friendly Health Systems Initiative and various clinical management guidelines that recommend frailty be assessed in older adults undergoing evaluation for various conditions and procedures. So to help move this field forward, we've been working on implementing frailty into our primary geriatrics practice at the University of Chicago for over a decade now. Let's just walk through the experience of one of our patients, shall we? This is Ms. Esther. She's a 77-year-old woman who has a history of falls. She believes that she trips on things when she has these falls. She called our primary geriatrics outpatient practice to schedule a new primary care visit. The first thing that occurs is our scheduling staff conduct a Frail scale screener to all new patients referred to schedule an appointment in geriatrics, all brand new patients. The Frail scale includes 5 self-reported questions about fatigue, walking upstairs, walking a block, comorbidities, and weight loss. Patients who score 3 on this scale are referred to our specialty clinic for a more thorough evaluation. In this case, Esther scored 3 out of 5 criteria. Therefore, she was scheduled for a new visit in our successful aging and frailty evaluation clinic. So what is the successful evaluation and successful aging and frailty evaluation clinic, or SAFE clinic, as we like to call it at the University of Chicago? Well, in 2011, we started this consult and primary care model using evidence-based frailty and other tools in our evaluation. We started this in our outpatient practice to try to structure or standardize the comprehensive geriatric assessment, including a frailty evaluation. These measures help us provide an objective evaluation of risk, for example, preoperative risk. It helps us aid in early detection of deficits that we can address to maintain independence that we otherwise would not pick up. It also helps to frame our overall care planning. This model was quite successful and has been replicated in our kidney transplant clinic in 2017, and all of our older kidney transplant candidates undergo the same evaluation. Our baseline evaluation is a 1.5-hour comprehensive geriatric assessment, including as many evidence-based tools as we could possibly fit. This includes a formal frailty assessment as part of our comprehensive geriatric assessment. We specifically administer the frailty phenotype criteria. We use a standard electronic medical record note template that allows us to document the same assessments and measures across providers. Esther, in this situation, has a weak grip strength and low activity, indicating that she is pre-frail. We also more recently created a frailty electronic medical record tool in our flow sheets, allowing us to standardize frailty measurement and administration instructions across all providers and specialties. It also facilitates trending frailty over time. Once we have a patient's frailty status, we use the status to impact our medical decision-making in 3 ways. First, we use frailty status to augment our risk assessment. Second, we use a frailty status to address frailty manifestations. And third, we use a frailty status to frame our overall care plan. And I'll go into all of these in a little bit more detail. So first, to augment our risk assessment. At the end of our electronic medical note template, we include a summary table that translates our comprehensive geriatric evaluation findings into types or levels of risk across different comprehensive geriatric domains. It also allows us to highlight areas in which a patient's doing really, really well and maybe isn't quite so high risk. Frailty status is listed in the first column. We would interpret Esther's frailty status from this tool into our assessment and plan using some text such as the following. Esther is pre-frail, indicating slightly increased risk of morbidity and mortality following an acute stressor or acute stressors. She also has deficits in cognition, upper and lower extremity strength, disability, physical activity. See below for recommendations to reduce her risk. So we take this table and summarize it into our assessment plan text. For preoperative evaluation specifically, we have also created standardized language for geriatric surgical risk in this table to standardize how we interpret and communicate our geriatric risk to our referring surgical providers. This surgical risk is based solely on the patient performance across these several evidence-based tools. Second, we use a patient's frailty status as a syndrome in our problem list. In this case, Esther is pre-frail. This is an opportune time to intervene and hopefully delay frailty. We would make a plan to specifically address her pre-frailty manifestations, her weakness, and her low activity. We would identify and address any precipitating factors that might be accelerating her frailty. And we would also make plans to reduce her risk of any of the consequences of her frailty. Finally, we use frailty status to help frame our overall care plan. For example, for someone who is non-frail, regardless of their age, we would encourage vigorous exercise and tight control of chronic medical conditions. For someone who is frail, we might target sedentary behavior reduction first. We would minimize polypharmacy. We would have more frequent outpatient visits to avoid hospitalization. And we would make plans to address social isolation and any caregiving needs. In an ideal world, frailty status could be used at a population level to help direct the most vulnerable older adults to the highest touch care pathways. We currently do not do this at the University of Chicago, but it is on my radar. Having implemented the frailty phenotype measures into clinical practice in our SAFE clinic for the last 11 years now, I can attest that traditional brief clinical counters are far too short of a time to allow adequate routine frailty assessment, unfortunately. We've had to fight for hour-and-a-half-long baseline evaluations for many years, but it is so worth it. In addition, we have published how even subtle differences in protocol administration can lead to measurement differences in frailty and some of the components of frailty across providers and research staff. We have spent now a lot of time trying to standardize this at our institution, but more work is needed at a national level to encourage frailty translation across clinical settings and research studies. We also have very little guidance from the literature on how frequently we should be monitoring frailty, and a lot of work is needed in this space. There's also a lot of work to be done in the frailty intervention space. Can we improve older adult outcomes by reducing frailty? And if so, how can we do this quickly, especially for our surgical patients? Finally, at least 1 in 5 community dwelling older adults are functionally or cognitively homebound, and we have a substantial number of patients living in rural areas. The pandemic also highlighted the need to be able to do our assessments over telehealth. How are we going to do our frailty assessments remotely? I think this is a great area for future research. In summary, I hope you will agree that frailty is a valuable tool within the comprehensive geriatric assessment. A patient's frailty status can be used to impact our care decision-making in older adults in several ways, which I reviewed with you today. The clinical electronic medical record infrastructure can sometimes help facilitate standardization across providers, and it certainly helps us monitor frailty assessment over time. So use those tools if they're available to you. Certainly, future work is needed to help overcome some of these translational hurdles, and I look to all of you to help fill those gaps in the research. Thank you so much for completing this module. See the Frailty Science website for more learning opportunities. Bye-bye.